Good morning. So this is the morning of the 6th of July. It's just before 9 o'clock in the morning. I am just back from my second night at my hospital here in Texas, where I have deployed as part of the COVID response to help out down here in South Texas. I've been talking to some folks who have asked me some questions, because in my last video when I got here before I went out to work, a couple of folks had asked me a couple questions and asked for some more information. I'm not going to tell people exactly where I'm working, partially out of respect, partially because I don't think I should be speaking as a representative of these facilities or what's going on, partly because I just don't think it's professional for me as a traveler to be putting that information out there. So I'm going to be a little bit vague about some of these things that I talk about, but other things I'll try to be as specific as I feel is professionally appropriate to be. I didn't make a video yesterday after my first day on the floor for a couple reasons. One, I was really tired. It was a long first night. And also partially because some of the thoughts and feelings that I had, I wanted to confirm. I wanted to think about it a little bit before I shared some of those thoughts and feelings. And I'm glad I did, because A, I got some sleep and I felt better and I had a pretty good night last night. And also partially because some of the things I was thinking about I feel more sure of now. And I think that we've confirmed, well, I feel like I've confirmed for myself some of the thoughts and feelings that I was having. So what is all of that? So everybody's heard, Texas is getting hot, it's getting in trouble. ICU beds are filling up. The system is being overwhelmed. They're having this huge influx of cases. People are getting sicker. Younger people are getting sicker. I don't know what it was like before this, but I can tell you that all of that certainly seems to be 100% consistent with the facts and feelings of the people that I'm getting feedback from here on the ground. On Friday the 3rd, that day was pretty much orientation. It was onboarding and education and getting IDs and getting passwords for computer systems and Pyxis, which is a medication dispensing system. Just getting generally up to speed on being able to walk into the hospital setting and perform. We were told that the first day that we would be shadowing with somebody, and we would be, kind of getting some help learning the system and what was going on. The morning of the 4th of July, Saturday morning, we deployed our day shift people straight away. I really haven't talked to a lot of them about what they found, but I know that they went out there, they deployed, they went after it, and they got down to work. I'm in the night shift, so I got there the evening of the 4th of July on Saturday and walked in, and we were met with hospital administration and nursing leadership, who took our group of, I think it was 40-some people, and introduced themselves and pretty quickly intimated to us that they felt that they were kind of in a crisis situation, that they felt that they were at capacity, that their nursing staffs were stressed to the point of breaking, and having, for lack of a better term, having some very serious issues secondary to their staff feeling stressed, overwhelmed, overburdened, and so they were having a lot of trouble. They were kind of in crisis. So we got deployed pretty quickly. Everybody who came in with this group were all expected to be experienced, capable ICU staff. The needs of the hospital were more diverse than that. I think maybe about a third of the folks, of the 40 some we had in our group, I guess, maybe not even a third, it was about, so it was around, well, it was about a third, about 15 people, I think, got ICU assignments. I think there were 8 of us that were asked to go to the emergency department, and the rest of the folks were scattered between step downs, telemetry units, and med surge. But all of those people were expected to pretty much, in effect, perform in an ICU capacity, because their ICUs weren't just at capacity, they were absolutely overfilled. They had patients who would otherwise be in ICUs in their step downs. They had very sick people in their med surge and their tele units. They were making accommodations to be able to perform monitoring and care strategies in other units that were not consistent with that traditional level of care. In other words, they are running COVID ICU patients pretty much all over the hospital. For me, when I went to the ER, we walked in. I was pretty excited to get in there to try to lend a hand. I was one of the first folks through the door, and their staff literally stopped and clapped for us to welcome us, and that was sweet and kind of touching. That was nice. Those folks were upset. They were hurt. They were scared. They had people, and they still have people. Not a huge ER. It's a mid-size ER by some standards that I guess we would use back home. The ER I work in back home is pretty dang big. There are bigger ones, but it's a big, busy, deep water ER, and so this ER has about half the number of beds that we would have back at my home base. I think they had more than half of their beds were people who were waiting for mostly ICU beds. They were carrying ICU COVID patients for days, plural. People who were waiting for 3 and going on 4 days in the emergency department, being cared for by emergency department staff in an emergency room, waiting for an ICU bed. That is the very definition of overloaded ICU. So if you know anybody who is out there saying, oh, the ICU bed situation isn't that bad, what if that's your family member who is sitting waiting in the emergency room for days? What if they have a stroke? What if they have a heart attack? What if they have a trauma and they're waiting for that ICU bed because all of these folks are getting stacked up, and these COVID patients that end up in the ICU are there for a while. It's not like they're there for 2 days, not there for a day and then get stepped down. Most of these folks are there for at least a week, usually more, and they're sick the whole time, and they demand a lot of care because they are complex. They need a lot of effort, and they're soaking up those bed hours. So these folks were really happy to have us there. So that seems pretty real. It was pretty raw. It was pretty legit. Quick look around. They had multiple people in the hallways, multiple squads stacked up. Not enough people to get everybody checked in and look after them. They had day shift staff who had been working lots of overtime, who were staying over into the evening. They had night shift folks who were getting there early, trying to help out. They were stressed and at capacity and breaking, and so us walking in there was a huge benefit for them. So there's that. Um, the patients were also sick. I have not. I didn't work a whole bunch of shifts back home after coming home from New York and before coming here. Um, I worked my shifts, but for the most part, I was pretty happy to, be with my kids, recharge my batteries, and just kind of try to chill a little bit. So I didn't get to see as much action at home as I would otherwise, but I am absolutely confident in saying that the average COVID patient that I've taken care of back in Ohio is nowhere near as sick as the average COVID patient that I took care of in New York. Not even close. Um, Extremely different presentation, extremely different acuity level, and just very different. As soon as I walked into this emergency department, and I was in working with COVID patients within moments of walking in, it became pretty apparent that I was seeing acuity and illness patterns that were much, much closer to what we would see commonly in New York. That's something I can't explain. It's something I can't really wrap my head around. I'm not sure why. The average person that we're seeing here right now who has COVID is just pretty damn sick. And why all those folks that we're seeing in New York were all super darn sick. And why I wasn't seeing folks that were as sick in Ohio. I'm not sure what's up with that, but that's was what I saw. So so what's next for Texas? I don't know, but it's scary because we're still seeing an acceleration of folks getting sick, being diagnosed. So there's more people out there, and it's spreading relatively quickly. And we already have maxed out systems, and we have patients who are sicker than average. That's a recipe for bad things. So what's the good news? And there is good news. The folks who have deployed here with me, the nurses who have come in to help, are by and large a really professional, experienced group. More than half of the people that I'm working with are people who had experience firsthand, and pretty good experience firsthand in New York. So these are not rookies who are coming out here. And in addition, they all have extensive clinical backgrounds and good skills. So everybody who walks in is pretty much ready to just start going to work. And that was reflected pretty early on. For as bad as things were when we walked in the door at 7 o'clock on Saturday night, by 2 a.m., the charge nurse was coming out to me and he was happy. He was ecstatic because he felt like his ER was under control, and he felt like his ER was calm, and he felt like his regular staff that he had been working with, who were at a breaking point hours before, were more relaxed and felt like things were under control, and they felt safe because they felt like they could provide the care to their patients, and their patients were getting the care that they needed. And that, I think, is a direct reflection to what happens when you are able to apply sufficient staffing with good skills and who are ready to work. When you deploy that particular asset in sufficient quantity, it fixes a lot of problems. There is nothing more powerful in medicine than good quality staff who have the time and capability to do the job. There's no tool, there's no building, there's no piece of equipment that is as effective or as powerful or as valuable as qualified, tenured staff who are ready to go get it. Period. I feel that it's there's no arguing against that. People are welcome to say, well, wait, what about penicillin? I don't care. Good staff wins every head-to-head battle. Period. So it made a pretty significant difference pretty quickly. So that was good. And I felt like that was happening pretty early on, and that's one of the things that I was thinking, man, that's something I really want to talk about to everybody. But but I wanted to sleep on that. Boy, we're at 16 minutes. Let's get after this here. So last night, came in, everybody already knew their spot, everybody knew their position. The other thing was Saturday when we were talking about, your first day you're going to get somebody to kind of take you through. No, everybody got thrown right to it. Everybody rolled up their sleeves and went after it right away on Saturday. There was no orientation. It was roll up your sleeves and get to work. Find something that needs to be fixed and go fix it. And that's what everybody did, and it worked. And so that was pretty awesome. Once again, the power of quality staff and enough of it. So today, everybody pretty much walked in. Everybody knew the drill. There was no fussing, no nothing. It was just like a Swiss watch. The folks who were there in the day shift had a pretty much an under control situation. Once again, lots of boarded patients, lots of people on the board who had been there for a long time. But all of these people who are ICU patients, no problem. We had sufficient staff and sufficient capability. Everything worked. Everybody had a smile on their face. Everything was solid. Some continued fine tuning in the way that they manage things, but that's positive because you now have this added resource of sufficient professional capability that allows you to tinker with some things and let people specialize a little bit and try to adjust your flow in order to try to improve the quality of services that you provide your patients. And they were doing that on a weekend, on a Sunday. So that's a pretty good sign. So this morning, Monday morning, administration was coming in and they were like, hey, look at this. Good things may have happened over the weekend. And I think they did. So, now that administration is going to be looking at some of this stuff, seeing, the added capability that we have. We had some conversations over the weekend about things we're going to try to maybe implement, which I'm kind of excited about because I think that we can add some capability. Which I think we have to because I think things are going to get worse. I think that we're going to see more sick people, we're going to see more patients, we're going to see more people who are in deep doo-doo who need help pretty much right now. So that's a good thing. That's pretty much a recap of what my weekend was like. One of the things that and it kind of ties into this. Had a person ask me, how does our communication, the things that I got to be part of in New York and the things that we learned in New York that translated into changing patients' outcomes, how is that, because it moves faster than medical journals, it moves faster than research, it moves, you can't have a symposium in order to try to disseminate our findings. So how does that work? It's a good question. Nursing and healthcare and ICU and ER, it's kind of a small community in that I have friends in the ER community in California, in Oregon, in Washington State, in Texas, in Colorado, down south, Florida, Georgia, up in New York, and we all talk. And some of those folks watch things like this, and we watch reports from other people who were at bedside in New York, and we listen to internists and respiratory therapists and these folks who share this information, and it kind of daisy chains out. And so there's this kind of an informal network of people who share experiences, and it's quick, it's fast, and it's immediate. So I know when we were in New York, we had a lot of people laying hands on a lot of sick patients, and we were sharing a lot of information between us. Things that we found that we didn't expect. For example, pretty early on, a lot of the patients that we were taking care of were having really profound swelling, really big arms, big legs, swelling in hands and extremities, and the conventional wisdom is that's like a fluid overload sort of a thing. So there was kind of a conventional wisdom. You have fluid overload, give them a whole bunch of fluid. So sometimes, most of the time, that's exactly the right thing, but not always. We're seeing, for some reason, these folks who are really sick with COVID, they have a number of things that are counterintuitive in the way that they present. And even though they look like they're super wet and they're, kind of drowning in their own secretions, in other ways they're super dry. And so we try to dry them up, and some of that other stuff gets worse. So we shared some of our early things that we learned from that, and we're like, maybe we don't want to keep these people so dry. And we share that, and hey, we find out that maybe that's better to not keep them quite so dry. We had the whole thing of ventilators very early on. We need to have all of these vents. We need 50,000, 100,000 ventilators, and we need them all right now. We needed a lot of vents. We needed more vents. We got more vents. At the same time, that early conventional wisdom was we do not BiPAP these people. We do not give them high flow O2. We do not nebulize them, because it's going to nebulize and put this virus into the air like this big viral stew that's going to be floating around the room, and it's going to be super hazardous to all the folks that are trying to take care of these people. Not a invalid fear. It's a valid fear. But at the same time, really terrifying that we would take people who we thought had a good chance and we put them on a vent, and then shortly after they had really terrible outcomes. And other folks who we didn't have a vent for, or who we thought may not tolerate a vent, we would make a decision, hey, let's try BiPAP. So I'd strap on the big rig, full face gear, and we'd wrap ourselves in plastic bags, and we'd go in there and try to take care of these people on a BiPAP when it wasn't necessarily the safest thing for us, but we thought it was maybe the best thing for the patient. And lo and behold, we found out that it was working, and it was working well, and we were seeing patients have pretty strong immediate responses to this change in treatment that was not considered to be the right way to go. And so we were excited about it. We were talking about this back channel. And so, you have hundreds of nurses who are sharing the same hotel, who are working at a whole bunch of different hospitals, who are taking care of hundreds and thousands of sick patients. And you get a lot of data back real quick, and it's all anecdotal, and it's all kind of word of mouth, and it's kind of seat of the pants. But guess what? It bore fruit. It changed the way that we practiced hands-on at bedside. period, the information that we shared and that we passed back and forth between those hospitals in New York made a difference. It changed the way we practice. It changed the things that we as nursing staff advocated for to our physicians and to the medical teams, and they bought in because they saw the changes too. And so now we are taking some of these things that we've learned and we're taking it with us to Texas. These people took it back with them back home. There are people in Florida, there are people in Arizona, there are people all over the country now who were either directly in New York laying hands on people, learning these things and affecting change in our standard operating procedures, or they were 1 or 2 degrees of separation, and the things that we learned have been disseminated through to the whole country. And I think it's one of the reasons why we have seen a pretty dramatic change in some of the death rates. You can pretty much look at what was going on in New York City, and you can see directly on a graph when adequate help showed up in New York City, and we started learning some of these things, and we started sharing some of this information, and you see the numbers just, they change. So that was human hands-on learning that helped affect some of those numbers. And you're going to see, hopefully, a continuation in better numbers with death rates because of some of the things that we've learned. I'm very hopeful that no matter how bad things get here in Texas, we are not going to see death rates that are anything close to what you saw in New York. And I have already seen some people on social media who are like, well, we're not going to see these death rates like we saw because they're not going to try to inflate death rates for all these other political purposes in Texas and Florida the way they do in New York City. Bullshit. It is not politics. It's effective care from people who roll up their sleeves and put themselves in harm's way to go in there and fix patients and stop them from dying. And this is why I have told people, don't keep looking at death rates. Look at the ICU admits and the bed capacities and the lengths of stay, because that's going to tell you how sick the average people are and what's happening in general with the populace. So that's pretty much that. Not really sure what else to talk about with that, but so overall I think there's good things. I think those good things is that we're developing a system of care that works better. I think we're developing a system and a mechanism to try to get sufficient numbers of people with sufficient skills and good attitudes to where they need to be in relatively short order. We need to continue to develop that and make ready, because this is not going away super soon. This is something that's going to continue for a while. It's not going to be about a first wave and a second wave and a third wave. This is going to be like the tide. And the tide is going to roll out of Texas, and this tide's going to rise somewhere else. It's going to rise in Nevada. It's going to rise in California. You're going to see peaks and troughs, and you're going to see things heat up, and then they're going to boil over, and you're going to see this happening all across America. And it's not going to be easily predictable. The only thing that you can be sure of is that by the time you figure out that it's happening, it's too damn late. Because this is a fickle and nasty disease that we just don't really understand everything about yet. And so all these folks who demand that we have better data and this is all, I wish the world was as simple and as clear cut as these people want to imagine it to be, and it's not. So I'm going to get off here. I'm going to get some sleep. I'm going to go jump in the shower real quick and scrub off some skin and get myself tucked in bed because it's about 9:30. I get to get up a little bit later here than I did in New York. My hotel is only about a mile away, if that. It's a very quick trip. So I can get about an extra half hour, 45 minutes of sleep here than I did in New York. So that's a nice thing. So far so good. The people down here are super nice. Patients are easy to get along with. I need to learn some Spanish really bad. Next time I do a video, I'll talk more about what I'm doing specifically. I guess I've been kind of tasked with, I guess I'm kind of a triage specialist, which they wanted me to be, so I've spent a couple of nights out front, which is actually a little bit different than just triage. They have a system that's a little bit different, so I'll talk about some of that stuff. So about what I'm trying to do and what I'm doing and what my responsibilities are going to be in trying to keep all of this stuff moving. But hopefully I get good at it pretty quick and get good at their system pretty quick, because if and when this stuff starts blowing up, I'm going to have to be quick, efficient, and good at my job. So that's it for today. Still the 6th of July. It's about 9:30 in the morning. I'm going to go get some sleep. Please feel free to contact me if you have thoughts, questions, anything you want to know about. I'm really happy to discuss what I can and things that I'm seeing and the things that are going on. And that's about that. We'll call it a day. But thank you guys for enjoying and the positive comments about when I do these video blogs and the support and the kindness, and so that's that. So please be good to each other, love each other. Please continue to talk to folks when they talk nonsense about these public health issues. Try to offer them decent, honest, thoughtful feedback that doesn't make them feel too stupid, because we want them to be receptive to the truth and the reality, and we don't want them to just shut down and kind of polarize to this, because their stupidity will kill other people. So it's not the kind of thing that just affects them. So we need to continue to try to reach out to those folks and work with them as best we can in order to try to figure out how we get through all this. So that's it for today. I'm going to bed. Take care. See you guys later. Bye.